Good evening. I'm Dr. Yngvild Olsen, the Medical Director at the Institutes for Behavioral Resources Reach Health Services, and my apologies for not being able to be there with you in person, albeit virtually, this evening. But I am really excited to have the opportunity to describe to you very briefly the response that our clinic took in when the COVID-19 situation happened, and how we managed to continue to provide services for our patients. I have no disclosures to report, and I'm hoping that by the end of the few minutes that I have, that I'll leave you with 3 key principles in caring for patients with opioid use disorder during the COVID pandemic, apply 3 lessons learned from our clinical practice and what we learned during COVID, and then leave you with 3 key practice level questions to consider as this COVID situation continues to evolve. You've already heard from my colleague, Erin Russell, about some of the data that we're looking at. And so I'll just tell you that when the first case of COVID-19 was identified in Maryland in the week of March 2nd in that overseas traveler, and then the first community spread that was detected in on March 12th in Maryland, I was in Boston, and my initial thought was, oh my God, the world has completely been turned upside down. This is all surreal. And then immediately following that was my second thought, which was, how are we going to keep our patients and staff safe and make sure that we can actually continue to provide them with medication for their opioid use disorder that they depend on? And fortunately, we had the flexibilities in terms of the regulations that changed really quickly. So many of you probably know that on March 16th, SAMHSA waived the duration and treatment requirements for take-home medication for opioid treatment programs. We are an opioid treatment program, and so this was really key for us. There also, the SAMHSA and the DEA at the same time released some flexibilities in terms of prescribing controlled substances via telehealth. And so that allowed us to then also be able to continue buprenorphine for our patients, both new and established. And then finally, the OCR waived some of the regulatory requirements related to HIPAA and HIPAA-compliant telehealth platforms, which was critical for us since we really have not used telehealth prior to COVID-19. And because SAMHSA, my apologies, CMS, expanded Medicare coverage for telehealth, the state followed suit, and so we have then been able to provide telehealth services while still getting reimbursed. But just because a policy allows for a certain practice, you still need to really apply it based on sound clinical rationale. So principle number one that we went into this with is to really realize that balancing risks is at the core of clinical reasoning for the treatment of an opioid use disorder, any substance use disorder, in fact, any healthcare condition. We do this all the time as clinicians. And so in our case, really thinking about duration of take-home medication, frequency of in-person visits and drug testing, we do this already, even before COVID. But COVID added some new risks. And so we moved, in my mind, from a 2-factor to a 3-factor balance, where now not only were we needing to take into account the risks of inadequately or untreated opioid use disorder or substance use disorders, but also really thinking about some of the risks of expanded access to opioid agonists that we were now going to be providing to patients who may really not be very stable. And what was that going to do to misuse and diversion? And then thirdly, the risks related to COVID exposure and transmission, not only to the individual patient as they were venturing back and forth and traveling back and forth from our clinic, but also to our staff, and then to the public, because many of our patients take public transportation. So I wanted to give you just an example of a patient and how we kind of tried to modify some of our risk assessment. So this is Mr. W, the 58-year-old male. He's homeless, who was wheelchair bound for years due to an AKA. end-stage renal disease, receiving hemodialysis, and also has schizoaffective disorder with a severe OUD, but fortunately no history of an overdose. He also, however, uses illicit benzos, and he had been actually relatively stable in terms of his OUD on 100 milligrams of methadone a day until about early February. And then within the period of just under 2 months, he was seen in the emergency room twice for cough and shortness of breath. Both times his COVID tests came back negative. So when I thought about kind of trying to figure out how many take homes to give him, in my head, I tried to do somewhat of a risk balance assessment like you see on this slide. So in favor of longer duration of take-home medication for him was the fact that he was at really high risk for a COVID illness, for severe COVID illness, and that because of his homelessness, he probably was at some moderate to high risk of COVID exposure. And he had a lot of transportation difficulties because his wheelchair actually was chronically broken. So I thought, well, those are things that might mean that we need to give him the 2 weeks of methadone take-homes as allowed by the new SAMHSA flexibilities. But then I also thought that, he actually might have some high risks of complications from his ongoing opiate use disorder recurrence, which had happened just at the outset of COVID. And he's at high risk for an overdose, given also his use of illicit benzos. And that, giving him too many take-homes might actually put him at moderate risk for diversion due to his poverty and homelessness. So what we ended up actually coming out with was a plan where we contacted a homeless outreach agency for some shelter and transportation. And what he really wanted was to get his wheelchair fixed. We continued his methadone dose at the current dose. And then we changed his clinic frequency so that he was coming in Monday, Wednesday, Friday. And he actually really appreciated that because he didn't have a phone. And he wanted to maintain that contact and have a place where he could actually stay inside for even if it was just 5 minutes before he had to go back out in the cold. We gave him a locked canvas bag for medication storage and really sat down wearing all my PPE that we had in person to talk through kind of the safe storage, even within his wheelchair. We made sure he had a naloxone kit on his person. Talked to him a lot about COVID symptoms, physical distancing, overdose risk reduction education. And then we ended up getting one drug test after his last emergency department visit. Unfortunately, he made it really through those hospitalizations through most of the summer, but in early August, kind of July, he passed away in the hospital from multi-system organ failure, probably in the setting of, or possibly in the setting of COVID. But he was an individual, and we really didn't have time or the ability to do that kind of individualized assessment for every single patient. And so initially, we really made use of the flexibilities that SAMHSA had provided. So we moved all our stable patients who were coming twice a month to once a month, all those patients who were coming once a week to twice a month, and we gave everybody who was on Suboxone or buprenorphine at least several weeks worth of take-homes so that they wouldn't have to come back and forth and come out. We also created some structured specific protocols and procedural algorithms using kind of a management team where we modeled it after an incident command structure. And we made sure that we incorporated physical distancing into all our clinical encounters. Initially, we were thinking that we could actually try and continue some of our IOP sessions and individual sessions, but we quickly came to realize that that was not going to be practical. We discontinued all our drug testing, and only recently we started some of that. We then realized that, when the community transmission within Baltimore City became such that we really couldn't actually see people in groups anymore, and it was only for crisis services or crisis situations that we were able to see individuals. We have a screening protocol at our building entry that we have continued. We don't do temperature checks because that to me just seems to delay entry, as well as delay then and keep people in closer contact than they really need to be. It doesn't add much. And we have then even further reduced the number of patients that were in the building at any given time when that community transmission in April and May really became much more significant. And we ended up staggering patients. We staggered staff as well for a while. We also really made use of that telehealth, initiating phone outreach and counseling at a much higher rate than we had been doing previously, understanding kind of that isolation really was affecting patients. And because we didn't have as much PPE, we ended up putting together an algorithm to really try and conserve PPE, the little that we had, until we were able to get more. And we can still do a better job of this, but communicating to patients and staff really electronically and virtually. We're now doing all of our treatment team meetings, our team meetings kind of by teams virtually. In the last month or so, month and a half, we have kind of gone into what we're calling our phase 3. So starting some drug testing again, really using and employing an alternative medication delivery system so we can keep people either quarantined or isolated, or though for those individuals who are at very high risk for severe COVID illness, being able to keep them at home. We've even restarted some limited blood work in the last few weeks. And especially for those unstable patients, when we restarted some of the drug testing, and even before that, it became pretty clear clinically that there were some patients who just really couldn't handle even a week's worth of take-home medication. We've continued our universal face masking policy, our front door screening, and now we've really been able to go and use our management team meeting, not necessarily every day the way we were doing it at the beginning of the pandemic, but now just once a week. So the second principle was that, really during this unprecedented crisis where there's a lot of uncertainty, that we still have very good evidence for effective treatment of an opiate use disorder. And I relied heavily on the data, both from interim methadone as well as some of the buprenorphine studies, such as this one from Dr. Schwartz et al. That shows that just giving patients methadone alone without any of the other treatment services really does have a positive impact on people's use of other opiates, and both self-report as well as confirmed through drug tests. So that making sure that we were able to maintain people's medication continuity was kind of priority number one from the get-go. Same thing applies with buprenorphine. So this small randomized trial from 2016 that really found that even with just giving people buprenorphine led to significant reductions in the number of days spent using opioids, and not only then confirmed both by self-report, but also by drug tests. Because we know that obviously, I don't think it's any surprise, but stress, anxiety, and having to relive some of those adverse childhood experiences in the past are risk factors for ongoing substance use. And we certainly have seen that over the past several months. We've had more patients who are getting hospitalized for alcohol use and alcohol withdrawal, for example. So that we wanted to make sure that we were continuing to really keep people safe as much as possible. And to do that, we really looked at partnerships and strengthening the partnerships that we already had. So making sure we partnered with now the 17 recovery houses that we work with. We assigned one of our peer recovery specialists the role of recovery house coordinator, and she's done a phenomenal job. We have distributed 150 naloxone kits from the Maryland Department of Health and the Center for Harm Reduction Services. We still have many more to give out. Patients are saying that they already have them, which is why we haven't given out more of them. But we also partnered with the Baltimore City Harm Reduction Coalition and have been able to provide almost 160 syringe service kits that include fentanyl strips for fentanyl testing, drug testing, to patients that have really taken this as something, an extra service that we can provide in collaboration with this organization. Because I think we have seen, and some of the data around connectedness, that we know that whether it's across different countries, ethnic groups, age groups, that really finding engagement with positive social support networks is associated with less substance use. That's certainly true for adolescents in this COMPASS study that's in the first bullet here, but we also know that that's true for adults. And we have learned some lessons from our use of telehealth, as I'm sure you all have as well, that involvement of counselors with that trainee status has been critical. But we've also seen that it's not just the audiovisual platform. We actually have a minority of patients who have access to that, and that about 50% of our patients only have access to a phone. So being able to use that phone and get reimbursed for those phone services is crucial. And patients have justifiably been very worried about their COVID risk. 60% of our patient population is over the age of 50, and there's a high percentage of those health conditions that really put people at risk for severe COVID illness. So, I don't envision that telehealth is going to completely take the place of in-person visits, but it certainly has been an extremely valuable addition. And then finally, our key principle number 3 was that, this is a pandemic that's really a rapidly evolving public health crisis. And so in order to stay abreast of what's happening, that we need to understand that some of the related guidance is going to also potentially change quickly. That was certainly true at the beginning of this crisis. Not perhaps quite as true now, but that making sure that we understand that what we're talking about today may change tomorrow. And so having access to these reliable sources, the ASAM COVID web page just got updated as of September 18th. So I would encourage everybody to go and look at those new updated guidances. There are over 15 of them. But there are a whole host of other national and state level guidances as well. So thank you. I really appreciate the opportunity to be able to still share this information with you. And if you have any questions that aren't able to be answered this evening in the live portion, please don't hesitate to email me. Thank you.